Hi, we're going to discuss today a very important topic, which is flat foot or bisplanus in children. This is a very common complaint. You will hear that frequently from parents that their children are have flat foot. So what are the objectives of this lecture? The objectives is first, we would like to identify the causes of a flat foot in children. We would like to describe the normal development of foot arches in children, and we would like to differentiate between physiologic and pathologic flat foots, and at the end we would like to outline the pathology in tarsal coalition. But remember that this lecture is going to speak about causes of flat foot in children. We're not going to speak about causes in flat foot in adults. A good source that you can use to read more about this is the book which is called Pediatric Orthopedics, a handbook for primary care physician. This book is written by myself and Dr. Naga. So let's first speak about normal development of the foot arch. This is very important in this topic. What is the normal development of foot arch? So for a newborn, if you get a footprint of his foot, you won't see a big arch, and the normal adult arch that we see is not gained around except around the age of 8 to 10 years old. So newborns are born without foot arch. Around the 4 years old, you start to getting a small arch, and the normal adult arch is usually gained around the age of 8 to 10 years old. These two curves shows this fact. In the first curve, we compare the middle part of the foot to the posterior part of the foot, or the midfoot to the hind foot, and obtaining the normal adult curve is usually not gained except around the age of 8 to 10 years old. This is a study done radiologically to show the development of the foot arch, and the normal arch is usually radiologically not obtained except around the age of 8 years old. So to summarize, the kids when they are born, they don't have an arch. Around the age of 4 years old, they have a small arch, and the normal adult arch is usually gained around the age of 8 to 10 years old. So normal toddler again have a flat feet. So don't be afraid if your child has a flat feet if he's 2 or 3 years old. And also for pediatrician, don't refer kids at this age for a flat feet, because normal toddler have a flat feet, and this is because of two facts. There is abundance of subcutaneous fat, and there is laxity of ligament. So again, children less than 4 years old don't have an arch at all. Between 4 and 8 you start having some arch, and the normal adult arch is usually gained around the age of 8 to 10 years old. Why is that? Because of abundance of subcutaneous fat and ligamentous laxity. And here is a similar picture to the one that we saw before. Small kids, toddlers don't have an arch. Around the age of 4 to 5, you start having a small arch, and the adult arch is usually obtained around the age of 8 to 10 years old. So what are the causes of flat feet in children? After we discussed the normal development of arch, let's now discuss the causes of flat feet in children. So if you get a child who's around 8 years old and he's still flat feet, what are the causes for this? There is two main causes. It's either physiological or flexible flat foot, or pathological flat foot. So a flexible flat foot, we're going to discuss that in detail. Pathological flat foot, there is causes for pathological flat foot. The most important causes are tarsal coalition, we're going to speak about that. Accessory navicular, we're going to speak also about that. And Achilles tendon spasticity in various disease. So flat feet is in children is divided into two main categories. The first one is the flexible flat foot, and the second one is pathological. We're going to see how we can differentiate between these two now. So flexible flat foot, let's start with flexible flat foot. It affects about 12% of the population. This is extremely important, so you have to reassure the family that this is a normal finding. It's present in about 12% of the people, and the arch can be restored easily by dorsiflexion of the big toe, as you see here, or by tiptoeing. So flexible flat foot, this is extremely common, and you have to tell the family that this is basically a normal variant and not a disease. It affects lots of people. It affects about 12% of the population, and when the child presents, you will see the picture like this. He has obvious flat foot. He has a valgus heel, which means that his heel is pointing outward. and you see fullness here, which is collapse of the talus. But if you ask the child to tiptoe, that's you will see obviously here his arch, or if you dorsiflex the big toe, you will also see the arch here. Flexible flat foot very rarely cause pain. The child will present because his family are worried about that. They are worried about the deformity, or they may complain that the child is wearing his shoes more. And if you look to the shoes, you will find that there is more wear on the inner side, which is the medial side, than more than the lateral side. They may complain that the child walks funny. However, it is extremely rare that people have pain from flexible flat foot. So again, flexible flat foot, it's a common finding. It's a variant of normal rather than a disease. Affects about 10 to 12% of the population. When the child presents, you will be easily able to see his flat feet. There is fullness on the medial side. There is valgus here, valgus heel. If you ask the child to tiptoe, or if you dorsiflex the big toe, you will find restoration of the arch. This is another example of a flexible flat foot in an adolescent girl. If you see she's standing here, you see her from behind. There is obvious valgus heel. It means that the heels are pointing outward. There is obvious flat feet or pes planus in both legs. And the moment we tell the patient to tiptoe, you can obviously see she has a restoration of her arch. So this is another good example of a flexible flat feet. Patient is standing, you're seeing her from behind. She has bilateral valgus here. The heels are pointing outward. She has flat feet. If you see fullness here medially, bilaterally, and you ask the patient to tiptoe, you can see restoration of the arch here and here, and also the heels started turning inwards. So this is a flexible flat foot. So let's speak now about types of pathological flat foot. So we spoke about physiological flat foot. Now we're going to speak about pathological. Most common cause of pathological flat feet is a tarsal coalition. Tarsal coalition, the old name of tarsal coalition is peroneal spastic flat foot. So what is tarsal coalition? Tarsal coalition means that there is an abnormal connection or bridging between two tarsal bone. So the tarsal bone should be separated. If there is abnormal connection between them, that's called tarsal coalition. Please note that this tarsal coalition starts as usually fibrous, but then when the child grows up, it changes into a cartilaginous, and then later on becomes a bony coalition. What is the incidence of this condition? This condition affects about 5% of the population. So 5% of the population have some sort of tarsal coalition. And the condition in the vast majority of cases is usually asymptomatic and bilateral. So this condition affects about 5% of the population, but in most cases it's asymptomatic. Most common coalition is the coalition between the calcaneus and the navicular. It's called calcaneo-navicular coalition, and between the talus and calcaneus, and we call that the talocalcaneal or the subtalar coalition. So what is the clinical presentation of tarsal coalition or peroneal spastic flat foot? So by history, usually the patients present around the second decade of life. It's usually around the age of 10 years for those who have a calcaneo-navicular coalition, and around 13 to 14 years for those who has talocalcaneal coalition. So this condition does not present early. It presents in the second decade. It's usually around 10 to 12 years old for those who have calcaneo-navicular coalition, and around 12 to 14 years old for those who has talocalcaneal coalition. Why they present in that age? Because this is the age in which coalition progress from being fibrous to being cartilaginous or bony. Also by history, there will be a stiff flat foot with foot pain, so the family will come complaining of flat foot, and in the same time there is a history of foot pain. Also, there might be recurrent ankle sprains. This is a common complaint among those who have a tarsal coalition, because they don't have a normal subtalar motion, so they have less accommodation to changes in the ground and the floor, so they get more recurrent ankle sprains, and they usually continues to have pain after this ankle sprain. And then when you examine the child, you will see decreased subtalar motion. So if you try to put the foot into supination and pronation, which is bringing the foot outward and inward, you will see that there is decreased subtalar movement. It will be a stiff flat foot. So we described before how can you see that flexible flat foot can obtain its arch when you dorsiflex the big toe or when you tiptoe. That does not happen in tarsal coalition. So with exam, it will be a stiff foot. It will be a stiff deformity. There will be decreased subtalar movement. And also when you palpate the peroneal tendons, these tendons are behind the fibula. You will find them spastic and tender because they are trying to stabilize the foot. Hence the old name of this condition, which is peroneal spastic flat foot. So again, clinical presentation, it usually appears in the second decade of life, around 10 years for those who have calcaneonavicular coalition, and around 14 years for those who have coalition between the tarsal and the calcaneus or the subtalar coalition. It's a stiff flat foot with a foot pain. There is history of recurrent ankle sprains. When you examine the foot yourself, you'll find decreased supination and pronation, which is the movement that happened, the subtalar movement and the subtalar joint. So when you try to bring the foot into supination or pronation, it will be much less than normal, and then the peroneal tendons are spastic and tender. So let's discuss now the x-rays of the tarsal coalition. So again, there is two main types of tarsal coalition, the calcaneonavicular coalition and the subtalar coalition. Usually the x-rays can detect most of the calcaneonavicular coalition. However, the subtalar coalition is a little bit harder to detect in the x-rays. So this is a patient. If you see clinically, he has valgus feet or flat feet. X-rays, here is the oblique view and here is the lateral view. In the oblique view, this is the calcaneus bone, this is the navicular bone. Normally you should have about 8 to 10 millimeter separation between them. If you see in this x-ray, there is a connection between the navicular, which is projecting more towards the calcaneus, and a projection from the calcaneus projecting towards the navicular. So there is a coalition here. In the AP, in the lateral view, you can see that the calcaneus is protruding forward, this process here, and this is what we call the anteater sign because it looks like an anteater nose. So this is the X-ray picture of a patient with calcaneonavicular coalition. In the subtalar coalition, it's harder to detect in the X-rays. So in cases of subtalar coalition, X-ray is harder to detect, so we proceed to a CT. So this is a lateral radiograph of a patient with a flat foot. If you see, he has loss of arch. This is a standing X-rays. There is complete loss of arch. You don't see the regular arch in this X-ray. If you look closely here in the X-ray, this is called the C sign. It is the overlapping between the talus and the calcaneus and the hardening of the joint. So if you see this line here, that's what we call the C sign, because it looks like the letter C. You can see that in the lateral X-rays in cases of subtalar coalition. However, if you are suspecting subtalar coalition, so you get a patient with a flat feet, you assess his range of motion of the subtalar joint, and it is very stiff. You get the X-rays and you suspect that you have a C sign. The best thing you can do is to get a CT, and in the CT you will see the fusion obviously. So this is the CT of that same patient. This is a coronal reformat. Here is the talus, here is the calcaneus, and obvious you can see here the connection between the talus and the calcaneus, which is abnormal connection. So let's discuss now another cause for a painful flat foot, which is accessory navicular. What is the definition for the accessory navicular? Accessory navicular is an accessory ossicle on the medial aspect of the foot, just medial to the talar head. So this is the talus, and this part of the talus is called the talar head. This is the navicular bone, and this is an accessory navicular. There are few types of accessory navicular. It can be separated, as you can see here. You can see the separation, or it can be as a continuation of the main navicular bone. This is a common condition. It happens about 10% of the population has an accessory navicular, but remember, the vast majority of these cases are asymptomatic. So this accessory navicular is another cause for a painful flat foot. Most cases of accessory navicular are asymptomatic. They are found as accidental finding when you get an X-ray. However, sometimes it can cause pain on the medial aspect and a flat foot deformity. what is the treatment that we do. If the condition is asymptomatic, no treatment is required. If this was an accidental finding in the x-ray, you don't have to treat. If it's painful, the patient presents with a painful flat foot and you press on the medial aspect of the foot, there is pain, and then x-ray shows the accessory navicular. Starts first with rest, non-steroidal like ibuprofen or Aleve, or soft tissue insert that relieve the pressure from the navicular head and the accessory navicular. If all this does not work, you can refer for an orthopedic surgeon for possible excision, which is rarely indicated. So after we discussed two causes of pathological flat feet, which is tarsal coalition and accessory navicular, I'd like to discuss with you a third cause, which is Achilles tendon spasticity. So this is a picture for a patient with diaplegic cerebral palsy. You're seeing her from behind, and you can see the obvious flat foot deformity that she has. The reason of this flat foot deformity is that she has a spasticity of her Achilles, so her calcaneus is in equinus. So in order for her to compensate for this, she will dorsiflex in the middle of her foot. Dorsiflexion of the subtalar joint and the midfoot will result in valgus deformity. So spasticity of the Achilles tendon can result in compensatory valgus deformity, and we see that obviously in patients with spasticity like a cerebral palsy. Some of the kids which presents with flat foot has tightness of their Achilles tendon. That's why if you had a patient with a flat foot and you examine them, you find them have a tight Achilles tendon, one of the things that you can do is refer them for therapy for stretching of Achilles tendon. So again, Achilles tendon spasticity, one of the reasons for pathological flat feet. The patient will try to compensate for the spasticity of the Achilles tendon by pulling his foot upwards, and because of the mechanics of the foot, when you try to dorsiflex or pull the foot upwards, it goes into outward deviation. I'd like to conclude the lecture with a common question that I get from parents, which is, what is the best shoe that I can get for my son or my daughter? This is a very frequently asked questions I receive all the time in the clinic. I tell the families that shoes are for protection. They are not corrective for deformity. So shoes are mainly protective for the child foot, and they are not going to correct deformities. So the most important thing for a shoe, it has to be soft and comfortable. So soft, comfortable shoe is the best thing that you provide for your son or daughter. And I tell families, soft means that you can put the shoe in between two fingers and squeeze it. That means a soft, comfortable shoe. Avoid high heels for children. This is very important. It can cause problems for them. It can cause problems in their back or ankles or the Achilles tendon. And avoid tight shoes. Always have the shoes that can easily accommodate the toes. And cushioned sole will give more protection. So cushioned sole will give more protections for the kids. And remember that built-in arch does not result in long-standing effect. So shoes which has built-in arch are okay, but the family should know that this will not result in long-lasting effect. Thank you very much.